So now I'm going to use two cartoons along with a picture of one specimen to contrast the normal anatomy with the situation as we see it in tetralogy fallow. The cartoon that I'm showing you here is illustrating the roof of the right ventricle. Here the tricuspid valve, here the pulmonary valve, and this of course is the aorta with the right coronary artery. And what we see shown in yellow is the membranous septum, and as you can see, the hinge of the tricuspid valve crosses the membranous septum, dividing it into atrioventricular and interventricular components. Here on the septal surface of the right ventricle we see the prominent muscle bundle that we call the septomarginal trabeculation. In the United States, this structure is frequently called the septal band, and its anatomic features are that it has a body which extends down towards the apex of the right ventricle, and then at the base of the ventricle it splits into these two limbs. The posterior-inferior or posterior-caudal limb gives rise to the medial papillary muscle. The anterosuperior or the anterocephalad rim runs up towards the pulmonary valve. We can then see the extensive muscular shelf that forms the larger part of the supraventricular crest or the crista supraventricularis. As I've already shown you, that is part of the inner heart curvature, and we also call that the ventriculo-infundibular fold because it interposes between the ventricle and the subpulmonary infundibulum. Now what I emphasize to you in the normal heart is that there is a small part of the supraventricular crest that you now see as the yellow part of the crest, which is a true muscular outlet septum. But in the normal heart there is no way that we can tell where the muscular outlet septum finishes, where the inner heart curvature begins. So it is these two components together that we call supraventricular crest, and that supraventricular crest then supports the freestanding muscular subpulmonary infundibulum. The other muscular bundles that are going to be of particular importance in tetralogy fallow are then these septoparietal trabeculations that run from the anterior surface of the septomarginal trabeculation and extend to the parietal wall of the right ventricle. Now we can see that very well in this dissected heart, where I've illustrated the supraventricular crest, and I've cut it away to show you that it is largely the inner heart curvature, or the ventriculo-infundibular fold, and that inserts between the limbs of the septomarginal trabeculation, or septal band. And here, at the union between the fold and the septomarginal trabeculation, is that sliver of myocardium that represents the true muscular outlet septum. But as you see, in this normal heart, there is no way that we can tell where the fold stops and where the septal component begins. And then this heart shows us also very nicely the septoparietal trabeculations running to the parietal margin of the right ventricle. And there, supported by the fold and lifting the pulmonary trunk away from the base of the ventricle, we have the freestanding subpulmonary infundibulum. So that all changes in the setting of tetralogy fallow. And what I've illustrated here is the picture looking from the apex of the right ventricle towards the base, so that here again is the tricuspid valve. This is the aortic valve now overriding the right ventricle, and here the narrowed subpulmonary infundibulum. And this is the interventricular communication. And I've shown you an example in which the membranous septum is a direct relation to the interventricular communication. We'll see that when we move on to our specimens. So here is the septomarginal trabeculation, or the septal band, and the feature of tetralogy is that the interventricular communication, or the ventricular septal defect, is between the limbs of the septomarginal trabeculation. But what we can also now see is the extensive inner heart curvature that is supporting the part of the aortic valve that arises from the right ventricle. And this is the part that we now name the ventriculo-infundibular fold. But the essence of tetralogy is that the building blocks of the outflow tract have now come apart, so that now we see the outlet septum in its full glory, because now we see this muscular structure that interposes between the outflow tract to the aorta from the right ventricle and the outflow tract to the pulmonary trunk from the right ventricle. So now we can truly identify this muscular structure as the outlet septum. And it is, of course, deviated relative to the limbs of the septomarginal trabeculation, and it's deviated in anterocephalad fashion. There is still a freestanding infundibulum supporting the leaflets of the pulmonary valve. That is narrower than the normal, of course, but oftentimes it retains considerable length. So there we see the subpulmonary infundibulum. But now the important additional feature of tetralogy is the presence of these septoparietal trabeculations, because it is the squeeze between the deviated outlet septum and the most superior of these septoparietal trabeculations that produces the narrowed mouth of the infundibulum that is, in most instances, one of the characteristic features of tetralogy of Fallot.